3.5 billion people, that's nearly half the world, suffer from oral diseases, and yet most of them will never sit a dentist's chair. Why? Because they live in communities without clinics or cannot afford care. So, how do we fix that? That's exactly what community dentistry is all about. Not treating one patient at a time, but improving oral health for everyone, everywhere. Stick with me, and by the end of this video, you will think like a public health dentist. First, let's meet the doctor who is going to guide us through this lecture. This lecture comes from Dr. Sikander Munir Memon, Assistant Professor and Head of the Department of Community and Preventive Dentistry. Think of him as your guide from the clinic to the community. And the core idea is simple but powerful. Serving communities, not just patients. That's the heartbeat of community dentistry. You are not waiting for someone to walk in with a toothache. You are going out to schools, villages, factories to prevent problems before they start. So, what exactly will you learn today? Let's look at the learning outcomes. By the end of this video, you will be able to define community dentistry like a pro, explain how it's different from clinical dentistry, use real indices like DMFT, and even design a basic oral health program for a low resource community. Sounds big? Don't worry. We'll go side by side. We start with the three key definitions you must remember. These are the 6 levels of learning we will climb today, from simply remembering definitions all the way up to creating your own community program. Don't worry, I'll give you real examples at each step. So, what is community dentistry? Let's nail the definition. Here are the 3 definitions you will see in exams. Community dentistry is the science and art of preventing disease through organized community action. Public health dentistry focuses on populations, not one person, and oral public health aids society's organized efforts to improve quality of life. Remember, all 3 say the same thing. We work for the many, not just the few. But this didn't appear overnight. How did community dentistry come to be? Community dentistry has evolved from simple charity dental camps in 1800s to a full scientific discipline. The big leap came in the 1940s with the community water fluoridation, one of the greatest public health victories. Today, we have global strategies from WHO and FDI. And behind it all is a powerful philosophy. Let's break down 6 core principles. 6 principles guide everything we do. First, the community is our patient. We use epidemiology to diagnose its needs. Second, prevention first. It's cheaper and fairer. Third, equity and justice. Oral health for all, especially the poor. Fourth, community participation. Programs fail if people are not involved. Fifth, intersectoral action. Oral health links to nutrition, education, poverty. Sixth, evidence based practice. We use data, not guesses. Quick question. If a community has no toothbrushes, will telling them to brush twice a day work? No. You need to provide brushes or find alternatives. That's intersectoral action. Now, how is this different from what you learn in clinical dentistry? Let's compare. Here is the big difference. In clinical dentistry, you wait for the patient to come to you with a cavity and you fix it. That's reactive, curative, one person at a time. In community dentistry, you go out to schools and villages. You give fluoride and education before the cavity forms. That's proactive and preventive. whole populations. Both are needed, but community dentistry tackles the root cause. So, what exactly are we trying to achieve? Let's look at this aim and objectives. The aims are the big dreams: promote oral health, prevent disease, reach the underserved, and train dentists like you to think community first. The objectives are the concrete steps: do surveys using indices like DMFT, find high risk groups, run fluoride programs, and even advocate for national policies. You're not just a dentist, you are a health leader, and that leadership covers a huge scope. Let me show you the 8 domains. Community dentistry isn't just about pulling teeth in a camp. It includes oral epidemiology, studying disease patterns, surveys to measure burden, preventive dentistry like water fluoridation, oral health education campaigns, policy, writing laws, international work with WHO, training future dentists, and research on what works. It's a huge, rewarding field. But oral health doesn't exist in a vacuum. Many factors shape it. Let's see the big picture. Here is a key insight: oral health is not just about brushing, it's shaped by your income, your education, the fluoride in your water, even the price of sugar in your local shop. A poor child who eats cheap sugary snacks and has no fluoridated water will get cavities no matter how many times you tell her to brush. That's why community dentistry looks at the determinants, the root causes. Pause for a second. What's one determinant in your community that affects oral health? Think about it. Now, how do we actually prevent disease at each stage? That's Leavell and Clark's model. Leavell and Clark gave us 3 levels. Primary prevention happens before any disease, like community water fluoridation or sealants in schools. Secondary prevention catches disease early, screenings, ART fillings, scaling. Tertiary prevention limits disability after disease is established. Dentures, jaw rehabilitation, palliative care. Most of the clinical dentistry is secondary and tertiary. Community dentistry focuses on primary because stopping disease before it starts is cheapest and the best. There are some misconceptions. Many people think prevention is just brushing, but at the community level, prevention means changing water supplies, taxing sugar, and training teachers. That's way more powerful than any toothbrush. But you cannot do it alone. Who is on the community dentistry team? You might think the dentist is the star, but in community dentistry, it's a whole team. The community health worker speaks the local language and goes door to door. The nutritionist fights sugar. The epidemiologist crunches the numbers. The dentist leads and plans. Without the team, you are just one person with a drill, and that's not enough for a whole village. To measure the community's oral health, we need special tools, that is, indices. Indices are the thermometer of community dentistry. DMFT counts decayed, missing, and filled teeth. A higher number means more disease. CPI measures gum bleeding and pockets. OHI S looks at plaque. DAI checks how crooked teeth are. And Dean's index maps fluorosis from too much fluoride. With these, you can compare villages, track progress, and prove your program works. Knowing the number is one thing, changing behavior is another. Let's talk education and promotion. Education is telling people to brush twice a day. Promotion is making sure they have fluoridated water and affordable toothbrushes. Education says don't eat sugar. Promotion taxes sugary drinks. Both are needed, but promotion creates lasting change. The Ottawa Charter calls this building healthy public policy, and that's where real impact happens. Now, let's see all this in action. Real community programs. Here are four classic programs: School Dental Health, you screen kids, apply sealants, and even do supervised toothbrushing. Tobacco cessation, you use the 5 A's: ask, advise, assess, assist, arrange. Community water fluoridation, the single most cost effective measure, reducing cavities by up to 40%. And mobile camps, taking dentistry to remote villages. In dentistry, we do not have water fluoridation, but salt fluoridation is being explored. Which program would you start in your hometown? Think about it, then comment below later. But why is all this is so urgent? Let's look at the global and local burden. These numbers are shocking. 3.5 billion people have oral diseases. That's more than the population of India and China combined. Untreated caries is the most common health condition on the planet. Oral cancer is the fourth most common cancer in South Asia. In Pakistan, over half of school children have cavities. Two-thirds of adults have gum disease. And in rural areas, there's only one dentist for every 5,000 people, while WHO recommends one per 2,000. The gap is huge and preventable. What's being done about it? Here are the global and national policies. The WHO's Global Oral Health Action Plan aims to get 1 billion more people access to oral health services by 2030. They want oral health integrated into primary care. In Pakistan, we have a national oral health policy from 2007, but it needs updating. The Sehat Sahulat card covers some dental procedures, and lady health workers are now being sensitized to oral health. But we face funding gaps and a rural urban divide. The way forward: integrate oral health into non communicable disease policy and increase the budget. Knowing the problem and policies is great, but how do you actually plan a program? Let's walk through the cycle. Every community program follows this cycle. First, assess the community, do a survey, calculate DMFT, find risk groups. Then, plan, set objectives, budget, choose interventions like fluoride varnish or education. Then, implement, run the camps or school sessions. Then, monitor if you are on track. Finally, evaluate. Did carries go down? Then you go back to assessment and improve. It's never a one time thing, it's continuous. You have learned a lot. Let's test your thinking with some real questions, and then I'll give you a summary. Here are the questions you should be able to answer after this video. The last one is the big one. Design a 6 months program for elderly people in a rural area. That's the create level, the highest. I'll put a link in the description to a template you can use. Before you go, let's quickly summarize the key takeaways. Let's wrap up. Community dentistry is about organized efforts to improve oral health for whole populations, not just one patient at a time. Its 6 principles put prevention, equity, and evidence first. It's proactive, not reactive. We prevent disease at 3 levels: primary, secondary, tertiary. We measure with indices like DMFT, and we run programs in schools, villages, through policies. That's the big picture. Now I have a small assignment for you and then a call to action. Here's your 60-second homework. Think about your own neighborhood or village. What's one determinant, like lack of fluoride, high sugar consumption, no dentist nearby? And what's one community action you could take? Write in the comments. I'll read and reply to the best ones. If this video helped you see dentistry in a whole new way, hit the like button. It really helps the channel. Subscribe and turn on the notification bell so you don't miss the next lecture, where I'll show you exactly how to calculate the DMFT index in a real community survey. And comment. My community action is I'm excited to read your ideas. Thanks for learning with me. See you in the next slide.